Good evening, everyone. I am Dr. Sushrit Chandra, MBBS MS General Surgery, and today we are going to talk about the anatomy and physiology of parathyroid gland. So, the parathyroid are a group of usually four small glands embedded in the posterior aspect of the thyroid gland. It may topically be located in the neck or the chest, and the glands are usually the size of a grain of rice and measure about 3 to 5 mm and weigh about 30 to 60 mg only. So they usually exist as two pair, the superior parathyroids and the inferior parathyroids. The superior parathyroids are classically located near the posterolateral aspect of the superior pole of the thyroid, about 1 centimeter superior to the junction of the recurrent laryngeal nerve and the inferior thyroid artery, and they lie deep to the plane of the recurrent laryngeal nerve. And the inferior parathyroid glands are classically located near the inferior poles of the thyroid glands, within about 1 to 2 centimeters of the insertion of the inferior thyroid artery into the inferior pole of the thyroid. They lie superior to the plane of the recurrent laryngeal nerve and thus create about a percentage sign when you look at the relations of the recurrent laryngeal nerve to the superior and the inferior parathyroid gland. The location is much more variable than the superior parathyroids, which we'll learn why in a while. They can be intrathyroidal, they can be intrathymic, they can be closer to the mediastinum, within the mediastinum, or even be found along the arch of the aorta. So coming to the embryology, they develop about at 6 weeks of gestation from the endoderm, and they are derived from the third and the fourth pharyngeal pouches. The superior parathyroid is usually derived from the fourth pouch, while the inferior from the third pouch. They are functional during the gestation and control the calcium balance in the fetus. The fetal calcium levels are usually higher than the maternal calcium levels. So coming to the histology, they usually comprise of predominantly of two cells, the chief cells and the oxyphil cells. Chief cells are the smaller, more abundant cells which secrete parathormone, while oxyphil cells are larger and they increase with age. As you can see, the oxyphil and the chief cells along with the blood vessels in the micrograph of parathyroid. So there have been multiple studies, and one of those has been shown to you. This is a meta-analysis comprising of about 26 studies. Contains a lot of patients, 81% of which had only 4 parathyroid glands, thus making it the most common configuration. About 15.9% of these patients had parathyroid in ectopic locations. 11.6 were in neck, 51.7% of which were ectopics located in the paraesophageal space or within the thyroid gland, and 4.3 of the remaining 15.9% were located in the mediastinum. There have been no significant differences when examining these patients, even when they were healthy patients or hyperparathyroidism patients or cadaveric or intraoperative studies. So the vascular and the nervous supply. The blood supply is predominantly from the inferior thyroid artery, though some branches of the superior thyroid also provide vascular supply. Venous drainage is through the thyroid plexus of veins. Parathyroid veins ultimately drain into them. Lymphatic drainage is into the deep cervical lymph nodes and paratracheal lymph nodes. The nervous supply is by the cervical sympathetic ganglia. So coming to the function of the parathyroid glands, these produce PTH, the parathormone, which is the main regulator of the calcium levels in the blood, and its function is thus maintaining a proper balance between the calcium and phosphate, and it is thus crucial for the normal functioning of the muscles, the bones, the heart, the nervous system, and the kidneys. The parathormone is a polypeptide hormone and it maintains the calcium homeostasis, and it inversely affects the calcium levels. Uh, the parathormone starts as a 115 amino acid pre-pro parathormone, which is later converted, cleaved into a 90, and finally into a 84 amino acid parathormone. So, whenever the calcium levels are low, the parathormone secretion is stimulated, which leads to an increase in the osteoblastic activity in the bones. The number of osteoclasts increases, thus, greater bone turnover is seen, leading to an increased release of calcium and phosphate. It also affects the intestine and increases the absorption by uh, increasing the active form of vitamin D in the kidneys, and calcium reabsorption and phosphate secretion is again increased in the kidneys. All of these lead to an increase in the blood calcium. So the regulation of this secretion is mainly governed by the serum ionized calcium. In cases of a decrease of serum ionized calcium, a decrease in the active form of vitamin D, which is 1,25 hydroxy vitamin D, and increase in phosphate, it leads to an increase in parathormone, while the inverse leads to a decrease in the parathormone, and these levels are usually sensed by the calcium sensing receptor, or the CASR, which is again a site for pharmacological activity in calcium metabolism. So there are multiple forms of calcium in the body. Most of the calcium is stored in the bones as hydroxyapatite, and in the serum it is 45% free ionized, which is the physiologically active type, 45% bound to the proteins, which is predominantly albumin. Therefore, the total serum calcium concentration is adjusted to reflect any abnormalities in albumin, which is the major calcium binding protein, and the formula used is measured total calcium plus 0.8 times 4 minus the patient's serum albumin, thus giving us a corrected calcium. The other 10% is complexed with anions like citrate, sulfate, and phosphate, and this typically is measured as total calcium, the combination of all three, in the routine blood samples. So again, as seen previously, they are GI sources or enteric sources of calcium, that is calcium from food or calcium from the digestive juices, which is lost again uh, in the excreta, and the absorbed amount is then again lost in the urinary excretion, and finally the residual is absorbed in the bones. Coming to the phosphate metabolism, most of the phosphate again is stored as hydroxyapatite, and most of the remainder of the body's phosphate is intracellular as ATP, DNA, ADP, and phospholipids. A very small fraction is circulating phospholipids. Inorganic phosphates are again physiologically active, and typically inorganic phosphates are the ones that are measured in routine blood tests. So the mediators of this balance are obviously the parathormone, which we talked about, which increase the release of calcium and phosphate from bones and stimulate formation of the active form of vitamin D in the kidneys, reducing the calciuria and increasing the phosphaturia. Vitamin D again leads to an increase in the calcium and the phosphorus through absorption via the GIT. There's calcitonin, which is of low physiological importance, but it acts as a counter hormone, which decreases the uptake of calcium in the GIT, increases calciuria, and reduces bone resorption. There's also FGF23, which increases phosphaturia. After exposure to the sunlight, 7-dehydrocholesterol is converted into cholecalciferol, which is vitamin D3, and gets activated into diol form through livers, and finally converted by 1-alpha hydroxylase in the kidneys under the influence of the parathormone into 1,25 cholecalciferol, which is the calcitriol, and the active form of vitamin D. So coming to the normal laboratory values for calcium, we usually take serum calcium values, and normally 8.5 to 10.32 or about 10.5 are the normal values in mg per dl. Ionized calcium is taken from about 0.9 to 1.3 millimole per liter, and for serum phosphate it is about 2.5 to 4.5 mg per dl. Intact IPTH, we take the serum values as about 15 to 65 picogram per milliliters. Thank you.